now post lunch, and the first speaker is Dr. Kanchi from Bangalore, India, and he's going to speak on ventilation in EV.
I would like to express my gratitude for the invitation, and it's indeed a great pleasure and honor to participate in the ninth annual International Conference of the SWAC also being conducted at Ludhiana. Uh, I'll be dealing with the ventilation strategy in VV Ecmo in the next 12 to 13 minutes. VV Ecmo is a therapy in the management of respiratory failure that is unresponsive to conservative management. I have no disclosures to make. And to start with, I would like to deal with a case of a 23-year-old male who presented fever, dyspnea, and dry cough, and on admission to the community hospital, he was hypoxemic, requiring oxygen therapy. His X-ray showed bilateral haziness, and he did not improve with the um, oxygen inhalation, and he promptly needed endotracheal intubation and mechanical ventilation. He fitted the criteria for adult respiratory distress syndrome, and the ARTSNet protocol was applied to maintain the ventilatory status. However, this did not result in a great improvement in the respiratory function with continued hypoxemia, unresponsive to increased oxygen, inspired oxygen concentration and PEEP. He was prone and neuromuscular blockade was instituted, and this did not result in a great improvement. And he was suddenly exposed to the harmful effects of mechanical ventilation. His Murray score was greater than 3, and the venous ECMO was instituted. And what are the goals of respiratory support for VV ECMO? The goals basically are maintain the blood oxygenation and carbon dioxide removal, at the same time provide lung protection and lung rest by reducing the tidal volume, plateau pressure, FiO2, and respiratory rate. The VV ECMO can be used as a bridge to lung recovery or bridge to lung transplantation. The key principle of lung protection during VV ECMO is that gas exchange is primarily supported by the extracorporeal circuit, not the native lungs, and thus the ventilator setting should be chosen to limit the ventilator-induced lung injury. However, the optimal ventilator strategy in patients with severe ARDS undergoing ECMO is not well defined. Historically, typical ventilator settings during VV ECMO are pressure control mode with FiO2 of zero point 0.3, plateau pressure of 20 centimeters, PEEP of 10 centimeters, respiratory rate of 10 breaths per minute, and the initial inspiratory expiratory ratio 1 is to 1. If you look at various publications which are not only retrospective but also prospective multi-centers trials and meta-analysis, it's clear that the amount of intensity of ventilation has been reduced after the institution of extracorporeal life support. The tidal volume is reduced, respiratory rate is reduced, the peak plateau is reduced, and the compliance is improved. And this shows the cumulative frequency distribution of tidal ventilation and the driving pressure before ECMO and first 2 days on the ECMO. It is evident that the tidal ventilation is reduced, and similarly the driving pressure is also reduced. The mechanical power, which is a composite of tidal volume, peak pressure, respiratory rate, also is decreased with the application of ECMO. Does extracorporeal removal of carbon dioxide help these patients when they are in ECMO? This elegant study published in JAMA 2 years ago did not demonstrate the benefits of instituting extracorporeal carbon dioxide removal in patients who were on BV ECMO. The results show that there was no difference in the outcomes at the end of 90 days. Similarly, this data from Toronto Intensive Care Observational Registry showed that the mortality with increasing dynamic driving pressure is greater with increasing the showing increased effects of mortality with the use of increased driving pressures. Effect of prone positioning on ARDs requiring ECMO. This publication, which was done about a year ago, shows that the patients who were prone early during the course of treatment with ECMO had better outcomes as compared to those with late application prone position. And coming to the near apneic ventilation in experimental models of ARDS, near apneic ventilation maintained the pulmonary alveolar architecture much better than compared to conventional protective strategy or non-protective strategy. The next issue is whether you would like to extubate these patients while on BB ECMO. This must be considered. In fact, as many as 30% of the patients on BB ECMO get extubated when they are still on ECMO, and the advantage of extubating them and having the patient awake is to encourage their participation in physiotherapy and respiratory, deep breathing respiratory exercises. It is associated with less delirium, and the patient is able to eat, drink, and communicate with the family members and the medical team. But on the con side of it is that the patient will become restless, it may increase patient discomfort, and in some patients, the work of breathing may be high, leading to high oxygen consumption and higher carbon dioxide production. The other aspect we need to consider when patients are on VV ECMO is the how is the right ventricle doing. The right ventricular function is absolutely essential, especially when we are uh, thinking in terms of being these patients. The right ventricle is assessed by using the fractional area change and the tricuspid angular systolic excursion and the reasonable right ventricular function with a tap say of greater than 14 millimeters is necessary for them to be safely of the ECMO once the pulmonary condition is resolved. This picture shows the venopulmonary extracorporeal membrane oxygen using Protec Duo. This WMN catheter passes through the intrajugular vein of the right atrium into the across the right ventricle into the pulmonary artery. The one lumen which ends in the right atrium extracts, takes the blood from the right atrium, gets it oxygenated, and pumps it back in the pulmonary artery through the other lumen. And this aids in patient ambulation and physiotherapy. Liberation from IV ECMO must be considered when there is considerable improvement in the respiratory disorder exhibited in the improvement in the radiological findings as well as in the blood gas findings as you are reducing the sweet gas FiO2 to the oxygenator. Is a patient on ECMO who is being extubated, and this screening protocol from VV ECMO may be instituted depending upon whether the patients are um, on patients or breathing spontaneously or on mechanical ventilation. In conclusion, the institution of venovenous ECMO enables marked reduction in mechanical ventilation. The ventilatory tidal volume can be reduced to less than 4 ml per kilo of ideal body weight. The pre-plateau, that is the plateau pressure, can be reduced to less than 25 centimeters of water. Similarly, the respiratory the FiO2 may be reduced, can be reduced to prevent VLE, that is the ventilator-induced lung injury. And Before I conclude, I would like to invite you to the 8th International and 17th National Transesophageal Echocardiography Workshop being conducted in Bangalore in the month of August. The dates of 16th to 19th. Please join us. And thank you so much for this opportunity. And if there are any questions, I'll be happy to deal with them. Thank you once again.
Thanks, Morida. We'll try and leave the questions to the end. Yes, we got the speaker still online. So it's my pleasure now to introduce the next speaker, Dr. Jumana Yusuf Haji. She is ECMO director at Fortis Hospital, Mumbai. She's got extensive experience with ECMO and organizational aspects as well as setting up awake ECMO programs, which is a special interest as well. So Jumana is going to talk about her experience with awake ECMO patients and let's hear how she does it.
Thank you very much for this invitation, and it's my pleasure to talk on a topic which I'm very passionate about. Because for me, ECMO is an opportunity to decrease morbidity. It may have a mortality benefit or not, but it definitely has a morbidity benefit because there's a lot you can do while the patient is on the safety net of an ECMO. So, when you say awake ECMO, what do you mean? It could mean ECMO before intubation or having a spontaneously breathing patient on ECMO with just comfort sedation, no muscle relaxant, how we are used to seeing the conventional patients who are sedated, paralyzed, prone. And hello, everybody. For me, the awake ECMO patients should also be ambulating or and participating with physiotherapy. So, physiotherapy, decision making, as well as just getting better. So I will just go in quickly on in ECMO before intubation. Is it feasible? Is it a good thing to do? Awake VV ECMO indications that should be explored. Advantages of spontaneously breathing patients versus the risk of spontaneous induced lung injury. Contraindications of spontaneously breathing patient and advantages of an awake uh, uh, patient as well as challenges, and finally, when you do it for VA. I know this is included in the VV section, but I think there are much more indications for awake ECMO in VA, so I will just go over all of them. So, ECMO before intubation, do we want to do it in lieu of mechanical ventilation is a question, and when we should do it. VA ECMOs with patients with cardiac failure, I feel, if caught in the right window, should always be awake so that you can bridge them either to a circulatory device, mechanical circulatory devices, or bridge them to transplant. So, in this paper by Thomas Langer et al., where they studied the pathophysiology, technical considerations, and clinical pioneering of awake extracorporeal oxygenation, the rationale they said was to start ECMO early to prevent in ARDS to avoid detrimental effects of ventilator-induced lung injury. But the challenge is always understanding the heart and the lung and the ECMO interaction, where most of the confidence is with the conventional and how when the patient is awake, the ECMO gets impacts or the patient impacts the ECMO, and how to manage and monitor this patient when awake. And the conclusion is that actually we don't have enough knowledge and we need to do more or study more to understand where is the survival benefit of awake ECMO versus standard of care. There is not much data available on the survival benefits of awake versus awake versus after conventional. And as we know, the Eolia actually pushed the boundaries and only used ECMO as uh, rescue therapy. So, some of the indications where you can or should consider before intubation would definitely be when a patient who decompensates and already has an end stage pulmonary disease waiting for transplant. This is an indication to directly go for an awake ECMO in a window so that they can be rehabilitated and they do not lose their muscle power to sedation, ventilation, and also are not exposed to ventilator associated pneumonias. Status astigmaticus may be one of the indications which has been documented where you don't cause or cause lesser bronchospasm when you're not trying to intubate this patient, you just take over the gas exchange. One of the papers by Dr. Kiran and all mentioned that immunocompromised patients, they are all-round bad candidates for any kind of invasive technique. But maybe and, yeah, these patients are better to go on Ecmo before intubation because pneumocystis carinii, especially the kind of lungs that they are prone to, or even CMV. These patients may be ECMO before intubation is a better idea. When there is definite contraindication to IPPV and intubation, as in pneumothorax or tracheal tumors, um, pneumothorax especially, this is what we saw in long COVID runs because of many cumulative days of ventilation. A lot of patients had pneumothoraxes even before intubation, and these patients actually became direct bridges to transplant because they had these BPFs which would just not resolve. So this was a good indication for patients, and I think a lot of awake ECMOs were tried during COVID. Whether they actually were a survival benefit is not yet documented. Finally, in my opinion, a type 2 respiratory failure, which would potentially need ECOR or a low flow venovenous ECMO, may benefit more from an awake ECMO versus intubation and ventilation strategies. So ECMO and ILD as bridge to lung transplant, conclusion of several papers retrospectively, which compared data of patients bridge to lung transplant with awake ECMO versus mechanical ventilation, found that you avoid ventilator-associated pneumonia, ventilator-induced lung injury leading to multi-organ failure, which would make the candidates unsuitable for transplant, a higher participation in physical therapy, short post-operative mechanical ventilation and shorter post-operative hospitalization, leading to better outcomes. Most patients who are bridged with anything to lung transplant don't have good outcomes. But I feel if you are going to ECMO, it should be in a window where you can do awake VV, because if they in a crash situation go on VA, you get a much lesser window to salvage these patients and save them. Hence, extracorporeal life support in its recent most advanced version shows great promise in improving the pre and post transplant life expectancy by giving a chance of getting an organ while preserving the physical homeostasis. Advantages of a spontaneously breathing patient is better tone of respiratory muscles and diaphragm, which improves the functional resonant capacity. There is lesser VQ mismatch. The negative pressure during inspiration improves venous return and favors lymphatic drainage. Definitely reduces your ventilator associated pneumonia and ventilator induced lung injury. However, these patients do tend to have a higher respiratory rate and higher pressures as measured on transesophageal echo, Doppler, done in this sheep study where they uh, studied the trace in awake spontaneously breathing sheep while with healthy lungs, and then when they were induced with oleic acid with ARDS, the respiratory rate went up quite a bit. And what they found was that in ARDS lungs, it takes a very high sweep to actually almost wash out 80% of carbon dioxide to control this respiratory rate. So if there are very high respiratory rate and transesophageal pressures, you may land up inducing what is called as spontaneous induced lung injury, which is not desirable. So ECMO is not recommended. Awake ECMO is not recommended when and it can be where spontaneous breathing can be counterproductive, like when there is extensive atelectasis and consolidation, or there is septic shock with persistent capillary leak, and in hyperventilation or in concomitant cardiac insufficiency, and in severe patient ventilator asynchrony, where you will see hyperventilation and uh, incidence of spontaneous induced lung injury. So, in a nutshell, you should not attempt it where there is a high PEEP requirement or the patient's consciousness level is not great. And also you have to consider ease of cannulation, cannula insertion, and the hemodynamic stability of the patient. The advantages are that there is facilitation with rehabilitation, there is improved delivery of inhalational medicines, patient engagement in spirometry, facilitation in patient communication, participation in decision making. This I found very important when I bridged a couple of our patients to lung transplant, because it was very important for them to understand, like all ILD patients, what they are getting into, and lesser ICU psychosis and better nutrition. The challenges, of course, are the interaction between an awake patient and the ECMO system. So, the high work of breathing, which may increase the oxygen demand and carbon dioxide production. Uh, Also, the transpulmonary pressure may be high, leading to spontaneous induced lung injury. There would be interference with the ECMO flow due to collapse of the IVC over the cannula which causes during deep inspiration, which causes a lot of chattering. So you may have to balance that. Then difficulty by giving sedation, difficulty in monitoring ventilation and airway pressures. There may be decreased clearance of secretions, and ECMO carbon dioxide removal may not blunt the patient's spontaneous drive, or may blunt the patient's spontaneous drive. So it just that may be a challenge. Awake ECMO as Awake VA ECMO as bridge to recovery is an excellent option, especially when a patient comes into your ER with a cardiogenic shock from acute myocardial infarction, and he has pulmonary as well as urine output dropping, or it is a tight left main and is stable but may crash at. I think this is when you just insert ECMO on the cath lab table and you go ahead. Myocarditis, another good indication for a VA ECMO. Aluminium phosphide, in my experience, I found that when the ECMO was initiated prior to CRRT, prior to intubation, these patients did very well. I lost two patients who were already intubated on CRRT because by that time what happens is these patients come in with high lactate, high acidosis, 60-40 BP, but they are awake and ambulating. I mean, they're quite conscious and young. If you try to intubate these patients, they tend to crash because they are not able to compensate the acidosis as the patient was doing spontaneously. So this is a patient of mine who came with aluminum phosphide poisoning during COVID times, and we had a FEMFEM VA ECMO, which we had initiated with just a little bit of ICU sedation, and she was fine in 4 days. We had another patient who we put on CRRT first. Initially, the acidosis came down, lactate never came down, and then slowly it started creeping up again. After which we put these patients start having broad complex arrhythmias. In that window, if you catch them, before that window, if you catch them, then they do recover. Takotsubo is another good indication, or post cariotomy if you are able to not come off CPD, which recently happened with a case of us. We came out on a central ECMO, came out and extubated the patient immediately within a day, and the patient did well. We came off the central ECMO uh, after 12 days. So basically, the shock is refractory to conventional treatments. There is a rapid rate of vasoactive drug escalation, where you may want to try an IBP first or may not. Trialing IBP first is not a bad idea because it always is synergistic with ECMO and it will help you with your afterload. And but you may go for ECMO immediately, or you can see AKI, acidosis, and rising lactate. I choose the ECMO window. I choose this as an ECMO window rather than a dialysis window because I can always piggyback all my extracorporeals on the ECMO circuit. When I am faced with a patient who has deranged LFTs, mottled skin, and looks like MODS, I consider that a late window to offer any ECMO in cardiogenic shock. So in this paper, we're improving outcomes in Intermax 1 category patients with pre-LVAD awake veno-arterial ECMO. They found that ECMO helped with biventricular supporting the biventricular function and stabilizing the end organ functions. And the aim was to assess outcomes of patients on awake ECMO before durable left ventricular assist device. Of the 83 patients who received durable LVAD between 2012 and 2015, 19 received awake ECMO. And of these patients, 84% did well compared to 67% who were on non-awake ECMO before in these Intermax 1 patients. So it allows bridge to next therapy and improves outcomes in these patients by downgrading the disease severity on the Intermax scale. ECMO is a direct bridge to heart transplant. What we found was patients were in the ECMO group were younger and more likely to have severely disabled functional status. They have shorter waitlist time, but they are more frequently ventilated than the patients in the continuous flow left ventricular assist device. However, if you have biventricular failure and severe RV failure patients, these patients are likely to be extubated and bridged directly from ECMO to transplant. So the timing of rehabilitation is usually once you meet the ECMO goals within the first 24 hours, you reorient the patient and maintain day-night reorientation, explain intervention. You find a sweet spot of sedation where the patient is comfortable but arousable, and if the recovery is anticipated to be prolonged, then you have to plan airway by either extubating the patient, putting the patient on CPAP, HFNC, or then doing a tracheostomy. Most of my VV ECMO patients actually, most all of them were awake after the first 24 hours, and I preferred an early tracheostomy over extubation because I think even during COVID, whichever patients were put on ECMO before intubation, they ultimately landed up getting intubated and tracheostomized. So that's my preference. And cannula planning has to always happen even before going on with mobilization and awake ECMO in mind. So you can go for a single site double bile cable double lumen cannula, which is larger, but it is technically difficult, and you may need cath lab or you may need PE and anesthesia for insertion. Besides that, doing a direct cannulation with left like IJV and femoral, the usual configuration, also patients can be mobilized because the femoral cannula is quite long. It will probably slip out just a inch or so, and I am very comfortable mobilizing on there. Similarly, with an axillary cannula for veno-arterial, it is a surgical procedure. So if it's an emergency, you can go fem awake and then change strategy at a later date. Specific challenges would be equipment failure, which will be catastrophic as patient is more ECMO dependent and the exchange more challenging. Loss of cannula would be catastrophic, and monitoring and lines and managing an awake patient is a psychological burden for the patient, relatives, and the staff. You need a one-to-one nursing, a lot of psychological counseling. You form a closer emotional relationship, so it makes it harder to die. And you need to plan physiotherapy every day for these patients and entertain these patients with books, physics, and television. So, in conclusion, I feel every ECMO program should aim to develop goals, methods, and protocols to have patients awake at all times and spontaneously breathing on ECMO. But you have to scale dangers and advantages individually. But it is mandatory in bridge to heart and lung transplantation, definitely required in prolonged ECMO runs waiting for recovery of organ function. Contraindicated in severe sepsis, capillary leakage, and severe ARDS. A team approach with role and responsibility assigned, planned cannulation, sedation, airway with objective to early ambulation, and daily physiotherapy with frequent evaluation of goal setting would help you reduce the morbidity that your patients face on ECMO and get them out of the hospital fast. That's a big cost benefit. I'll leave you with a painting of my father by my father, which shows that ECMO is a bridge. Use it wisely to rehabilitate your patients.
Good afternoon. Moving on to the next presentation of the session on post ECMO clinic by Dr. Arpan Chakravarti, Associate Professor and ECMO Physician at Apollo Multi-Specialty Hospital, Calcutta.
This is Dr. Arpan Chakraborty from Kolkata, India. I was the past president of the Ecmo Society of India in 2019, and I'm indebted to the organizers for letting me give this talk, which is very close to my heart. That is the post ECMO clinic, and I could not make it because of some personal reasons. So I'm giving it online. The post ECMO clinic uh, is a very unique thing where your ECMO survivor should go through, and how you see the ECMO survivors, how they follow them in their coming back to normal life. So this was a newspaper article came out in 2020, the latter part, where 43% of the COVID-19 deaths in India was in between 30 to 59 years of age band. And at that point of time, because of the pandemic, because of our lack of preparedness, probably we have not used enough ECMO on that part. But it has been covered to some extent in the second wave, which was very massive and for a short time. So today, my discussion is not on the how many deaths we have seen, how many lives we have seen, and how much respect we have given to those lives who has came out of that wonderful technology. Now, this is an article which came out in Anesthesiology in 2019, where quality of life and lung function has been uh, seen in the survivors of ECMO for acute respiratory distress syndrome. And that was a 1 year follow up for 34 ECMO patients and 50 non ECMO patients with PFT, with CT, and health related quality of life questionnaires. And they found in ARDS patients, the ECMO and non ECMO patients had similar survival and almost full recovery of lung function at 1 year, despite that ECMO patients having more severe respiratory failure at admission. Non-ECMO patients reported greater impairment of healthy related quality of life. Now, this is another article published in Critical Care with the long-term quality of life in patients with acute respiratory distress syndrome requiring extracorporeal membrane oxygenation for refractory hypoxemia. Now, they have seen that long-term survivors have similar physical health but decreased mental health, general health, and vitality and social function compared to other ARDS survivors, and unexpectedly poor return to the world. Now, if you see this table, the results of quality of life with the five questionnaires, that is problem with the mobility, problem with the personal care, washing or dressing, problem with the usual activities, pain and discomfort, and anxiety and depression. Whatever you give them some points, 5 points, and then you calculate how they are doing with you. Now, coming to the next slide, if you see, there's a long-term survivors of COVID-19 treated with extracorporeal. What has happened to them? Either they have doing very well, or they are chair-bound, or bed-bound, or they are in between where have some kind of restrictions in life. Now, coming to that, then Oracle study, which showed in that University of Colorado with the lead site with John Hopkins, Kentucky, and Virginia, they have done a study cohort survivors of COVID-19 ARDS, including those treated with ECMO, and they did a post-ICU clinic follow-up with quantitative measurement of physical, emotional, cognitive function. With a 6-minute walk test, spirometry, dyspnea scoring, those five questionnaires, depression screen, PTSD screen, and anxiety screening, and regression model has been analyzed. What their studies, the functional impairment was common a year following the use of ECMO in coronavirus 19, and all the majority achieved independence in daily living, about half return to the work, long-term anxiety, depression, and post-traumatic disorders are very much common, although. So, this is another question. It's a modified ranking scale of 9 questionnaires with 11 respondents or 12 item WHO questionnaires. We have made our own post-ECMO clinic questionnaires. Like, hello, Mister, how do you feel? Do you feel good enough to work like before? Do you remember your stay in the hospital? Was it good, bad, or fearful experience? Can you sleep at night? Do you need any medicines to follow to go to sleep? Do you wake up with nightmares? Can you speak like before? Do you notice any voice change? Do you feel breathless while talking or walking? Can you walk like before? Do you need any support? Does your feet swell or any cough pain? How are your wounds? Do you notice any color change, scar, keloid, any secretions or anything jutting out from them? Do you take medicines regularly? And your Have you been in fine with the previous office? Now, coming to that, this is a recent article published in NEJM with the post-ICU recovery in March 2023, and they have exactly written what we are following in our post-ECMO clinic. That is, the patient survived with the physical sequelae of a mood disorders. You have problems with the caregiver, problem with the children also, and nurses, ICU physiotherapists, and training. They have also moral distress and very perception of inappropriate care and burnout, anxiety, and fatigue. So they have culminated all the perspective of your ICU stay and the post-ECMO stay. Now, this is the thing what we do when a patient comes to us in the post-ECMO period. We do fill with that post-ECMO clinic questionnaires with the 10 points what we have told uh, uh, previous slide, and we follow them with CT scan or PFTs. This is a CT scan after following 6 months with that lady. She was on ECMO for 42 days with us, and she had a moderate obstruction with reversibility, and it treated accordingly. Now, coming to the PICS, that is the post-intensity care syndrome, what we see in the post-ECMO follow-up mostly can be divided into physical, psychological, and cognitive dysfunctions. Now, what are those physical? Most of the ICU acquired weaknesses, neuromuscular conditioning, prolonged use of steroids, prolonged use of muscle relaxants. And you need to have a pulmonary rehab and graded physiotherapy with that. Now, coming to the lung functions, mostly done by the PFT, serial PFT, 6-minute walk test or 2-chair test at your chamber, follow up with HCT at 3 to 6 months, echo and ECG. You can see for in myocarditis patients, high dose steroids, those who are receiving, and patients with acute ILD, they should go to the ILD clinic for continuation of steroid or not. Now, you have prolonged effects of prolonged ventilation, which are mostly the laryngeal dysfunctions or vocal cord damage. This has to be taken care of, and you have to give the vaccine for influenza and pneumococcus. Now, this is another case where we found a subglottic narrowing because of post-tracheostomy. We had to do an operation because dilation didn't give a good result with her. Now, next thing is the cannula site assessment. As you were cannulating patients, so the cannula site wound and scar has to be seen very well. That can form pseudoaneurysm, there may be deep vein thrombosis. Those are all very much evident in your USG, and you might need to remove all of sutures after 10 to 14 days. Is there any wound which is over and above the this cannula sites? So coming to the psychological sequelae, what do we see? There is a sleeplessness and anxiety, depression and PTSD, flashback memories and the hallucinations. So we have a stigma of ECMO that something has been put on me. I was not deserving at that point of time. What I should do? This is a stigma of ECMO that is very much there. You have to give a counseling, psychological counseling, take a help of the psychologist or the psychiatrist, or need to continue the benzodiazepines for those kind of PTSDs. Now, you have some amount of cognitive impairment, which is very much evident. Almost the incidence is almost 30 to 80%, and usually because of the prior hypoxic insult. Usually improves in the first year, and non-improvement requires a further imaging of the brain to exclude any bleeding or infarct or something else is happening in the brain. Now, this post-ECMO clinic also helps you to get a peer support. More and more post-ECMO patients, when they come out, they can take care of the existing ECMO patients and take care of themselves. They can get a peer group, and you can take help from them. There are some financial parts also. You can put a crowdfunding for a patients who are on long-term ECMO, and you can request people through their thing that put some crowdfunding thing, which is very much evident, which has very much helped in our pandemic during that. And survivors also sometimes take parts in the counseling of the ECMO patient and the family when they are putting prolonged long time or something brief is happening. So this is a very good thing when you have a pool of ECMO patients who are coming to your follow-up and they are getting used to with this kind of activities. Now, look at this lady. She was with us for 81 days during COVID time, and she was pregnant. And after pregnancy, she went into ARDS, and she was first 50 days she was and not working up. And then her lungs started improving, and she was there with us for 60, 81 days of GV ECMO. And she could come out after 112 days of ECMO. She was going home after 112 days, but on the right foot has a gangrenous change, and we had to go for a this amputation of his forefoot, and she was doing well. And after that, look at the rehabilitation she is doing with that kind of thing. And this is the effect of your regular exercise, regular monitoring of this kind of patients to help them come back to their normal life. So this is there is the satisfaction where you run a post-ECMO clinic to follow this kind of survivors till they go for a actual coming back to their life. Now, this is another patient we discharged after 90 days of ECMO. And look at the way when he went home, he first started walking at home, and our home care services has done it with that oxygen concentrator. Look at the joy of the small boy. He's looking after that. His father just started walking, and after that kind of illness. So this we follow regularly through video call or on regular basis. They cannot come to your chamber. We follow them at their home through home care agencies, because rehabilitation is not very much advanced in our country. We follow them at with this kind of support. This gives a very good outcome of this kind of patients. That professional, the physical come back to the life. Now, he is one of our colleagues who unfortunately got infected during that without when before the vaccine got started, and he was put on ECMO. And this is the way we actually mobilized him on ECMO so that he could regain his muscle power even after coming out of ECMO. And he was doing well. He was on ECMO for 16 days, and slowly he has started coming up. And after that, he actually sent me this video of his video at home after going home. He just sent me this video that I'm doing fine, and that ECMO has not taken away my fitness from me. He was a fitness freak guy, and he has readily joined work after probably after 3 weeks of hospital stay. So this is the thing we want, and this is the actual the post-ECMO recovery we see when we see this kind of follow up. Now, this is another patient who was with me for 38 days of ECMO, and we follow him at home by graded physiotherapy, how he is improving, and because he has this the underlying some connective tissue disorder and the joint pain, so he was on this kind of therapy for a longer time. So this is the way we follow them by the graded supervised physiotherapy. This is another patient who was on ECMO. He had some kind of limb ischemia, and was before discharge we discovered that he's having this kind of foot drop, which was he was an officer in his government office, and he was very upset with his leg. Foot is not moving well. Now, coming after a year of rigorous physiotherapy and the post-ECMO clinic follow-up, he is just doing fantastic, and he has no remaining foot drop with him. Now, in the post-ECMO clinic, the three things for the physical thing that we do is the mostly the thromboprophylaxis, whether we continue or not. We have to see the residual lung function, as we have told by PFTs and the CT scans, psychological boosting, and ask them for their professional comeback. And most of the time, there's a long ECMO survivors because of the illness. They might lose their job, they are economically crashed, and they are all dependent on the people. So you have to give a good psychological boosting till they professionally come back and started earning as the ECMO stage, and actual that is the actual idea of your follow up. Now, what we do in that thing, because immediate follow-up, what are the things that we see the oxygen or diet requirement is there or not? We see the fluid intake, they should not be overloaded. We see the thromboprophylaxis. We see the heart rate control, so ivabradine or beta blockers. and we see nebulizations is required or not, and anxiolytics for the in the form of benzodiazepine. So this is the way we follow them up, and serially measurements of the nitroBNP and the other for things up we do by the serial PFT and the chest X-ray at the 3 to 6 months. So this is a slide, but we show that how we follow this is an oxygen delivery system, where how we help them, our survivors. And this is a question asked to me: what is actually you do? I answered always that we are nothing but an oxygen delivery person where your lungs is not working. So this is the way you have to propagate your work to them who is required this kind of therapies. And thanks to Ecmo, these are all the doctors and the health personnel who got benefited on Ecmo during COVID. And she was one of the neurosurgeon who was on Ecmo with us for 25 days. She is my college senior also. She's a critically acclaimed photographer and a very good neurosurgeon. She came back to normal life and doing good, fantastic neurosurgery. And this is the recent pictures of one of our survivor with our physio rehabilitation therapist. She came to us for the third time follow up, a completely recovered person after the 25 days of ECMO. And this is another recent one. There's a hybrid ECMO we did, and he has been fine. He followed me in my chamber, and he had a groin wound which is a bit infected. We had to do some kind of debridement, and we are following him up in the post-ECMO clinic. And this is the another one who is waiting in my the next follow-up clinic one in the next week. She has appointed. She was with us for 50 days following a viral myocarditis, and she's doing fine. We have given appointment to that small lady for the post-ECMO clinic. So thank you. Thanks from the Apollo Multispecialty Hospital, Kolkata, where I am currently working, and thanks for the organizers again for giving me the opportunity to talk on that subject, which is very close to me. Thank you.
ECMO has definitely revolutionized the treatment of respiratory areas which cannot be managed with conventional non-protective mechanical ventilation. Any experiences or any comments from the house? Your experiences or your comments regarding ECMO during the COVID period? Any questions? Thank you for some very interesting talks. Just looking at the last talk on follow-up clinic. In our own follow-up clinic, we found a huge psychological impact of COVID on families and on patients. And just your thoughts on that and how we can better care for our patients to prevent that psychological impact. Arpan, did you hear the question?
Yes, sir. Thank you for the question. Am I audible?
Yes, please go ahead.
So the idea of this presentation is mostly because to address these situations, the psychological impact. Because in India, an ECMO patient when he got discharged from hospital, he lost his money or his job is at stake, or he has completely physically down. So these three things you have to take in considerations at your post ECMO clinic. You have to follow them up, and not only the physical thing comes up within next 3 to 6 months, but what will happen when he is a breadwinner of the family, or she has a family to run, what happened to them? So this creates a stigma of ECMO in the mind of the survivors. So you have to, as an ECMO physician, I am always keen on taking that stigma out, because whenever he or she go anywhere, he will tell this is, has been my hair is falling because of ECMO. My I have a bad scar because of ECMO. But he or she will not tell that I came out of that situation because of ECMO. So this continuous assistance from our side and mostly the regular talk, mostly regular follow-ups will make this thing easy, and so that they can take part in the counseling process for the next patients, next long patients, long follow-up patients where we are in trouble.
I have a question for you, ma'am. We talked about awake ECMO and we're talking about psychological burden. What would you prefer? An awake patient who understands what's going around, or a sedated, paralyzed patient on a ventilator who's on ECMO who doesn't understand what is going on?
I think the awake patient copes much better because they have means they're quite part of their treatment, one, and for the family also. Like recently, I had a patient with cardiogenic shock who came out with a central ECMO. He recovered to quite an extent, but didn't seem like we would be able to disconnect him from ECMO. So we counseled for transplant, and I got the wife completely refused ECMO transplant. She said that I will take my chances. So my whole aim was to not have her see a patient with dialysis, central ECMO, lying moribund, but a patient who's sitting. So I told her, don't stop my rehab. I did a tracheostomy because I couldn't extubate him. He was, uremic, and then we put him on. But the day we went in for the explant, he was sitting edge of bed, talking to his family. I told his family, take 2 hours, take your time. We go in. If things don't, do well, then you have your decisions time. So I think that's very important because for the family to see an awake patient plus the patient himself to participate in his care is extremely important in such big decisions. Thankfully, we were able to get him out with off the ECMO and he's recovering now. But it's very difficult for everybody to take a decision when you just see a patient who is, sedated, ventilated, paralyzed for 15, 20 days.
Yes, thank you.
Just linking the two things together, the psychological impact and the awake patient. I just remembered the example I mentioned this morning in my talk, the obstetric patient that was awake on ECMO and she delivered her baby and she had a chance to see her baby across, the ICU door. I saw her in our ECMO survivors night just after going home months after. And the first thing she mentioned to me was that she remembers the day I brought her baby across the door to see him. I thought when I saw her, she's gonna come and tell me, "Oh, I'm getting nightmares," or I remember you strangulating me, or something like this. This is what we all think about, hallucinations post ICU. But actually, this is what she remembered. So I think being awake has other elements in it, and maybe preventing the psychological impact that the patient will have post ICU discharge.
This could be the last question.
I'm Dr. Madan from Apollo in Chennai. We have done around close to around 8 months, of course, with Parrot, we are able to show a success of around 70%. Nick, unlike in your case, our case is different. Social support here is quite huge. Most of them come from joint family, and then if the elder is going to take on the younger will take away the job and then do the job. And around 70% of the people are not able to find the psychological things what you are seeing. It's not there here, fortunately. And we counsel the patient, relatives, and the patient. So only 30% of people who are doing a nuclear family and then they are the breadwinners have some secular issues, but most of them are okay here because social support here in Chennai actually it's quite good. I would say.
Thank you all the speakers for a great session. Coming up, we realize that critical care in general and ECMO more specifically has a great propensity to create disabled survivors. It has a huge burden on families, society at large. So as we learn how to do ECMO better, we need to figure out ways to make sure that our patients not only survive but thrive. And that's why the work Arpan's doing and everyone's doing is very important. Follow up our patients. Our job doesn't end